Good morning, everyone. It's just a short presentation. I picked some 4 cases of pustular psoriasis, and we'll look at what is specific in each case. So our first patient is called Larry. He's a 16-year-old male who presented with erythematous black patches and plaques with pustules, and this one's developed after stopping the treatment of prednisolone. He also had fever and general malaise. The other thing that was unique with this patient is that he has had pustular lesions on the axilla and the scapular region since the age of 7 years. So this is pustular psoriasis that started in childhood. There's no history of psoriasis in the family, and currently he was not on any other medication. So that is how it looked like. It was more generalized. This was after treatment when there was improvement. So when we did investigations, the blood culture, the skin culture, all of them were negative. HIV and VDRL was negative. A skin biopsy showed, and this is quite classical, it showed acanthosis with confluent parakeratosis. There's also hypogranulosis, and the classical thing is what we call spongiform intracorneal or subcorneal microabscesses. And when you look at the blood vessels, they are dilated in the papillary dermis. And there is perivascular lymphocytic infiltrate. What is missing in all cases of psoriasis is eosinophils. That's very important. So we made a diagnosis of GPP, that is generalized pustular psoriasis. We started the methotrexate and isotretinoin. All the lesions cleared, but over a period of time, he's been having localized pustules, and these localized pustules are controlled with topical corticosteroids. The second case is Sarah, a 32-year-old female who presented with generalized pustules with crusting 1 month before delivery of the 4th baby. She had had similar episodes during the 2nd and 3rd pregnancy. And in both the pregnancies, she lost the baby. So we admitted her for 6 weeks. We did an induction, started on systemic corticosteroids. Everything went down, and we started after the induction, we started on cyclosporine, and all the lesions cleared. Now, the unique thing with this patient is that after controlling the pustular psoriasis, she developed chronic plaque psoriasis. And during the 1st and the 2nd, during the 3rd and the 4th, and during the 2nd and the 3rd pregnancy, she went into remission without any chronic plaque psoriasis. But during this time, after using the medicine, she developed chronic plaque psoriasis, and she's been controlled with methotrexate and topical corticosteroids and vitamin D analogs. Our third case is Judy. She's an 18-year-old female. She had an infected pre-auricular sinus, which developed an abscess. When an IND was done, and after the IND, she developed pustules around the area of an incision, which later on spread to the scalp and to the axilla and became generalized. She was treated with flucloxacillin. She was changed to clindamycin, but there was no improvement. Tests, we did several tests. Blood cultures, all these have been done by the surgeons, and they're all negative. They're also thinking of a fungal infection. We did entapinafine, we did fast swabs, there was negative. Anna was also negative, but the skin biopsy was classical of generalized pustular psoriasis. We started her on methotrexate and isotretinoin, and she went into remission. We tapered the medication. I saw her 2 weeks ago, and she's doing well. The wound was healing, but occasionally she develops ulceration along on the scar. and some relapses, especially on the axilla and the groin. In our last case, so the special case about that patient is developing pustular psoriasis, which is triggered by surgical maneuvers on the skin. Then our fourth patient is Mary. Mary was an elderly patient, and she was a known patient with diabetes. She was on insulin. She was admitted with a high fever of 39.2 and generalized pustular lesions on the skin. She has not had any previous lesions. And she reported that 5 days before she developed these lesions, she was having a sore throat. And she was treated with cetirizine and amoxicillin. Now, when the patient was admitted, she was started on ceftriaxone, Efalcan, that is acetaminophen, and there was no improvement. So when I saw the patient the first time, I thought of acute generalized eczematous pustulosis, and I thought probably it was triggered by amoxicillin, and so stopped the medicine and started on dexamethasone. 2 days, so I did the biopsy, and as I wait for the results, started the patient on dexamethasone, and 2 days the patient passed away. Okay. So when I looked at the biopsy later on, there were no eosinophils, and this is what differentiates acute generalized eczematous pustulosis from generalized pustular psoriasis. Otherwise, clinically, it is very difficult to differentiate. And therefore, this was a case that was missed. The other thing was starting with dexamethasone, the correct treatment. So when you look at I'll just be touching a few places. So one of them is, if you look at the clinical features, there is erythema and there are pustules, and these pustules are sterile. And the affected skin is tender. It's not itchy, it is tender, it's painful. And patients have a high-grade fever. So when you look at some other things is that GBP may occur with psoriasis, vulgaris, or psoriatic arthritis. It can occur the problem. But if you see a patient who has pustules on psoriatic plaques, then that we don't call that pustular psoriasis. That is just the usual pustular psoriasis vulgaris with pustules. So you have to exclude pustules on psoriatic plaques. When triggers of GBB infections, you've seen one patient developed, so this patient, the last patient that we discussed that passed away, probably developed, the pustular psoriasis was triggered by the upper respiratory tract infection. Stress, medications, withdrawal of prednisolone in our first patient was responsible for pustular psoriasis. The classical thing that's not common, the other one we saw was in pregnancy, is surgical trauma. It is not indicated in many conditions as to whether surgery can actually induce, but there are few case reports which have been reported worldwide. When we look at the pathogenesis, we're not going to discuss pathogenesis, but I want you to look at the cytokine profile. And the most important cytokine profile in GBB is interleukin 6. And genetically, there are patients who have mutations in interleukin 6 receptors. And this is what increases the migration of neutrophils into the skin. Now, how do we make a diagnosis? You've realized that we're having a challenge in making diagnosis. There's no standard criteria. There is the Japanese criteria. The Japanese criteria centers mostly on clinical features and histological features. And if you have all the four, then it is definitely pustular psoriasis. In my practice, I use the Japanese criteria. The Eraspen the European rare, the European rare and severe psoriasis expert network criteria is not that comprehensive. And what they really take into account is the systemic inflammation. So you need to do quite an extensive investigation panel for these patients. I like the Japanese criteria and I use that one most of the time. So when it comes to treatment, one, there's no approved treatments. The second thing is that there are no randomized controlled trials. There are no standard guidelines. And commonly what we use is what we use for treatment of psoriasis. Steroids should generally be avoided because there's a paper that was published by Terence Ryan, and it shows that there is 25% mortality in patients with pustular psoriasis who are treated with systemic corticosteroids. So when I started that patient on dexamethasone, probably I contributed to the death of that patient. Okay, so there's a possibility. So how should we have treated these patients when they come with severe form? Cyclosporine remains the best. We're talking of our setup, okay? Infliximab will be the best biologic if you have the capacity. But for many of us who are working in counties and rural areas where we are not able to get the biologics, and also because of the cost, start these patients on cyclosporine. The main important thing when it comes to management of pustular psoriasis is the speed and efficacy. Speed and efficacy. You need something that will work very fast, get the results immediately, and calm the patient. So that is for acute cases. If you're having cases which are not that acute, then we can use acitretin. But for us, isotretinoin is an alternative. The only difference between acitretin and isotretinoin is the half-life. The isotretinoin has a shorter half-life. Methotrexate is good, but the response is very slow. So other second-line therapies that you can do is phototherapy, topical corticosteroids. You can do the biologics. Now, if someone comes in pregnancy, like the patient we were having who was pregnant, most of these patients come in the third trimester. So corticosteroids is used in these cases, okay? That still remains the treatment of choice. And can be given cyclosporine at 2 to 3 milligrams per kilogram body weight per day. And it's shown that at this dosage, there is a lower risk of developing side effects. So you can use that. But for second line, you can do phototherapy, and after delivery, you can give retinoids and phototherapy. So always remember that there are complications that are associated with GBV, and therefore these are the complications you can see beyond the skin, and this is why it can kill. So prognosis, it's unpredictable. You cannot tell how it will go. From my experience, that's what I've seen also. 40% of the patients will give on flaring, and they expect about 3 to 7% mortality in patients that you are taking care. And flares that are covering more than 30% of the body surface area should be treated as potentially life-threatening and managed accordingly. So GBV it's an important rare disease because of the mortality and the treatments we borrow from plaque psoriasis, and they are not as effective as it is in plaque psoriasis. There are many unmet clinical needs that we need to work on, and probably if we are able to work on something that will block the interleukin-6 signaling, then we'll have a better treatment of these patients. Thank you so much.